This is a 3 years old child present with shortness of breath and lethargy after a few days of chest tube insertion for non-traumatic causes. هتحتاج أطلع سكشن أو شيء دكتور؟ ها هي.
عفوا الهيستوري دكتورة، بس الهيستوري.
She had a chest tube insertion for a non-traumatic pleural effusion, and within a few days she started to become shortness of breath, although she didn't have it prior to the chest tube insertion, and became lethargic.
بس الأكزيال دكتورة، العفو، بس الأكزيال تشوف اللانج ويندو. يعني العفو أستاذ، multi section chest CT scan lung and mediastinal window show malpositioned chest tube and left side pleural effusion with severe cutaneous and pneumothorax and emphysema, surgical subcutaneous emphysema with atelectasis and consolidation of the left lower lobe. بس الكورونال دكتورة، والchest tube reaching to the mediastinum, which is crossing the and it's malpositioned for this case, and it's most probably
very good. Malposition of what?
Yes, of chest tube. It is it's reaching to the mediastinum. I think it is not for
right.
the. If it is for pneumothorax, should be it is in the upper lobe, and for the pleural effusion should be in the costophrenic angle, which is the most dependent part of the lung, and for there's pneumomediastinum, pneumothorax, and surgical emphysema, which is most probably the acute the deterioration of the condition, mostly due to the this condition, which is malposition or iatrogenic contrast معكم دكتورة.
يعني شو السيكولي مال المالبوزيشن؟ شنو
يعني هذا يعني الدكتور داخل بالميدستاينم شو اسمه هذا
يعني هذا السيكولي مالته الكونسيكونسز
هذا يصير بنيمو ميدستاينم
هاي واحد
pleural effusion could be leading to the rupture of the trachea or esophagus. The injury to the esophagus may lead to the aortic injury could be.
من إذن اللي شفته pneumomediastinum و pleural effusion surgical emphysema.
Yes.
pleural effusion لو امبايما صاير.
بس هذا ما نقدر نحكم بالبايما حتى نشوف شو اسمه كونتراست، حتى نشوف
مشي بابا زينه مشي الكيس. ايش تريد تشوف
Yeah.
الكونتراست؟
يعني حتى تشوف البلورال سبليتنج ساين، لانه بالنيتف صعب to discriminate between the empyema
صحيح.
and
You are right. صحيح. إذا نحتاج كونتراست بالdiagnosis of empyema to see the pleural splitting sign. You are right. وبعد شو مسوي؟ loss of volume اكو؟
yes, there's compression of the left side and somewhat not يعني mediastinal shift. There's no significant mediastinal shift and causing atelectasis and collapse of the left lower lobe. يعني هذا أعتقد هذا من نسوي you can search for the cause of the unilateral pleural effusion in the pediatric age, and could be for some congenital underlying congenital cause or systemic cause.
زين هم اصلا ليش خلي له chest tube دكتوره زينه؟
unilateral pleural effusion.
for the unilateral pleural
كان
effusion of unknown cause يعني.
اي نعم unknown cause.
yes.
شكرا شورش، عاشت ايدك. دكتورة
شكراً
غفران
أستاذ.
موجودة؟ شكرا. دكتورة غفران عدنان موجودة ويانا؟ دكتورة غفران؟ ما موجودة دكتورة غفران. هند دخلت ويانا، هند عبد الهادي؟ دكتور ومير؟ ولاء موجودة؟ ولاء؟ دكتورة ولاء؟ بقاء؟ دكتورة بقاء موجودة؟
نعم أستاذ، وياك إن شاء الله.
يلا بنتي بقاء، your opinion بنتي.
أستاذ
سمعتي شورش شو اسمه الديسكريبشن مالته والهذه، وقال اكو نيوموميدياسينم، اكو نيوموثوراكس، اكو سيرجيكال انفيزيما ولوس اوف فوليوم. انت شنو رايك؟ شو تقولين؟
يعني دكتور، هو مثل ما ذكر الدكتور شورس، عندنا مالتي سكشن تشيست سيتي سكان اوف تشيست، يعني اللي واضح سيرجيكال انفيزيما.
زينة سوي كورونال بنتي اذا تقدرين. زينة سوي كورونال. اي
المال بوزيشن اوف ذا تشيست تيوب واضح عندنا. السيرجيكال انفيزيما اوكي. اوسو يعني واضح عندنا البلورال افيوجن، عندنا كولابس، كونسوليديشن. يعني اي ثينك اكو فد برونكو بلورال فيستولا، لان دا اشوف يعني غاز فوساي داخل يعني يعني ويا البلورال افيوجن. ميبي يعني انجري وصايره برونكو بلورال فيستولا، بس يعني بس الكونكشن يعني ما دا اشوفه بصراحه بالضبط. الو الو
بقاء تسمعيني؟
عمي اسمعك هسه، بس قبل شويه لا ما كنت اسمعك.
اوكي. البرونكو بلورال فيستولا
يعني
how we confirm انه there is a bronchopleural fistula؟
المفروض اكو فد كونكشن يعني حتى لو بسيط اشوفه يعني بين هذا. شويه دكتوره حركي يجوز يعني نشوفه.
مشي السلايدات بابا.
يعني هو بصراحه not clear، يعني
بل.
ما لا اشوف واضح يعني. بس هذا اللي اقدر، بعد ما اقدر اضيف شيء ثاني. نيمو دياستانا بسيرجيكال انفيزيما، بعد ماكو في شيء ثاني بصراحه.
بقاء شو يسوي لهذا الكيس؟ هسه انت هذا شفتي اكو، خلي نقول مال بوزيشن مثل ما قال شورش للتشيست تيوب.
يعني المفروض يصحح المفروض يسحبونه هذا التشيست تيوب على مود يعني يرليف البيشنت.
صحيح. يعني أول شيء هم المفروض يسوون ريموفال، بس أنا والله يعجبوني يعني هو تشيست تيوب موصلي لي هنا الميدياستاينم شنو يعني ما دارتي زين أدري ما عنده حساب هو ما عنده كتاب يعني. زين سؤال بقاء أخير، إذا بلورال فيوجن عادة اندولينج in which site التشيست تيوب الصحيح؟
هو على ديبندت يعني اريا، مثلا
Excellent.
نيوموثوراكس راح يكون على
بينما
الابر،
نيوز
بينما البلورال
بالضبط
افيوجن راح يكون
يا
باللور يعني.
رايت. عايشة ايدك بقى، شكرا.
العفو.
نرجع على دكتورة زينة فاضل، تحكي لنا بنتي على الكيس وإذا عندي ستوك حتى نستغل الوقت. تفضلي.
Study a 3-year-old child present with severe gastroenteritis. So she admitted to the hospital during to routine show that there is an ultrasound revealed that there is a moderate amount of left-sided pleural effusion. Actually, she's asymptomatic. She didn't have any shortness of breath or fever, and it's also confirmed by the X-ray. So she had a chest tube. Within a few days of insertion, she started to develop, she became dyspneic and also febrile and lethargic. So they ordered a chest CT scan, which revealed, as my colleague mentioned, that there is a malpositioning chest tube traversing the oblique fissure, and also it's reaching to the mediastinum, causing pneumomediastinum pneumothorax and also hydropneumothorax, which we give suggestion of that it's an post-interventional emphysema and malpositioning chest tube. And this is the report that we give it to the patient.
بلي نروح للتوك. عندي توك مسوية.
Our talk today will be about the imaging criteria for how to assess the tubes and line proper placement. We will talk about briefly about the most important lines that we face during our daily routine. We will discuss briefly the NG tube, endotracheal tube, and chest tube, central venous line, and also briefly their stent. We will start with NG tube. Actually, the ideal position of NG tube, it's had to be at least 10 cm beyond the gastroesophageal junction. And because that gastroesophageal junction not directly visualized on plain X-ray, there's some other alternative way that we can depend on what we see here. We can depend that we will take the 11 and 12 vertebra from the lateral valves of it, about 1.6 cm. It will be considered as an accepted position for the chest for the NG tube. So the important point we had to assure that it's midline and bisect the carina, so to ensure that's not in the airway, and also below the hemidiaphragm to ensure that's just past the esophagus. The common malposition that we can suspect, it can be stay in the esophagus, didn't reach the stomach yet, or it may enter the airway or bronchus, for example, or it may be coiled in the upper airway and then descending down. When we see here, this this is the chest tube, which in the midline, bisecting the carina to ensure that's not in the airway, is still in the midline. Then it's descent to the left side and below the diaphragm. It's here considered as a correct positioning chest tube, NG tube. While here we can notice that there is a coiling in the upper airways. It's not descending down. And while here, it's first in the midline, it's bisecting the carina, but we found the tip ended here. It didn't below the diaphragm, so it's still in the esophagus. It's considered as still high. It needs to be repositioning to enter the stomach. While here, if we follow it, it first started in the midline, then it didn't bisect that carina. It's just going toward, deviated to the left side, and it's going down. It's here. There's a suspicion that it's in the left lower bronchus. It's not in the esophagus. It's in the airway. The same here. It starts on the midline, but then deviated to the right side and just getting upward to the chest with pneumothorax. Here, it's enter the left mini bronchus and then to the pleura. That's regarding the NG tube and the proper positioning. Now we will move shortly to the endotracheal tube. Actually, the endotracheal tube position assessment differ depending on the head position, if it's flex or extended or neutral. There is some minor variation, and also depend on the size of the trachea of the person itself. But what we recommend that endotracheal tube had to be within 5 cm plus minus 2 cm above the carina. We don't want to be either highly from that because this may lead to improper ventilation, or just down because when it's really near to the carina, it may deviate to the right main bronchus and lead to collapse of the left horn. And in the children, it's accepted that 1.5 cm above the carina. It's a little bit different from the adults. And actually, because the carina, we can't determine its exact location usually because maybe there's a technical factor, it's not clear, not proper contrast. We accepted that we need the endotracheal tube to be within T2 to T4 level. That can be a helpful another mark if you couldn't exactly locate the carina. For example, let me see here this case. This is an endotracheal tube, and this is the carina. It's here visible clearly. We see that it's nearly about 5 cm above the carina, and this considered as an accepted positioning and correct positioning of endotracheal tube. While here, if we notice, it's still okay, it's still in the passing in the midline, but let me focus more about it. Here, when we see it, it's actually neither in the trachea nor in the menobronchus. It's just beside it, adjacent to it. There's a suspicion it could be an esophageal intubation, and that's clearly demonstrated by this hugely distended stomach. So it's in the upper GIT, it's not in the trachea, so it had to be repositioning. It's impulse repositioning in the esophagus. While here, let me see, it's the endotracheal tube. It's just getting down to more on the left and leading, or more on the right. When let me calculate, for example, 1, 2, 3, 4, 5, it's just reaching the 5. It's not within the accepted. So it's going more to the right main bronchus, leading to collapse of the left lung. So we had to just repositioning it to ensure proper ventilation and to save the other lung. While here, on contrary, there is a very high level. It's carina far beyond this. So this will lead to ineffective ventilation and also maybe slippage. So here also we had to advance it more and to ensure a proper localization. While here also, when we notice, this is the carina, it's clearly here, and the endotracheal tube tip here, just near the carina. It's also lead to right main bronchus, not to the left, and we had to positioning it. Another thing that we noticed that there is an inflatable balloon, which not usually seen, but here is clear and it's overinflated. This will lead also to complication, for example, tracheal necrosis. So we had to ensure that also there's a proper, not overfilling endotracheal balloon. And actually that's regarding to the first two, NG and endotracheal tube. Any question till now? Okay, so we will move to the chest tube if there's no question. اوكي استاذ واضح الصوت؟
واضح بنتي زينة تفضل.
Regarding the chest tube, there is a few things that you have to put in mind when you try to localize the proper location of the chest tube. First, you have to ensure that the tip location, if for pneumothorax, we prefer it to be directed upward near the lung apex, while pleural effusion, we prefer it to the tip be to the downward, so inferior, near the lung base for proper drainage. There's what a side hole in the chest tube. Actually, it's used for drainage. So in the X-ray, it appears just like as a radiolucence line. You have to ensure that all these holes within the lung field, it's not outside the lung or in the subcutaneous tissue, because this leads either to surgical emphysema, it may lead to improper drainage. So also apart from the tip, and you have to ensure that the holes also inside the chest wall, in the lung field, and also avoid the misplacement. If you see in the X-ray that this chest tube may follow the anatomical direction of the fissures, you see it advance more, likely to be in the mediastinum, or you suspect a lung parenchymal, for example, there's a nearby consultation or hematoma, you can use X-ray, lateral AB, or you can also use a CT scan to ensure that there is no such misplacement. And also, you have to ensure there is no kicking of the chest tube, will lead also to inefficient drainage. For example, let me see here. This is the chest tube. It's first, there's no kicking. It's upward, so because there is an pneumothorax. And when we're looking further, this is what I called a hole. This is the hole, a radiolucence lines. This is the hole. We had to ensure there is no holes outside the lung field. There's no holes here. or outside that. So this can be considered as a normal or correctly positioning chest tube. Apart from the clinical, examination, for example, bubbles, and this, we just here assess the radiological finding to assess the chest tube. While here, if we have a closer look, we can see there's a surgical emphysema here. And when we see this is the hole, and also there is a hole in the chest, in the subcutaneous tissue, which lead to this mild surgical emphysema. So this chest tube need to be repositioning because it's considered as a malpositioning chest tube to improve the drainage. While here, it's the chest tube had just outside the lung field, and it's also approved by the chest CT, which actually didn't enter the pleural cavity. It's outside, also need to be repositioning. That's all regarding the chest tube. And we will move to the central venous line or CV line. When we discuss CV line, you have to put in mind that there is two lines. We have either to the left will follow a little bit direction. This is regarding the internal jugular, and subclavian will go toward the left, while here this is the right, and this is the right one. The important things that we had to notice first that this is the right subclavian. It's just below the clavicle, and this is important when you have to assess whether it's maybe arterial, not venous insertions. You have to remember that the vein follow the direction below the clavicle, and also this is the arch of aorta and the left brachiocephalic just above it. The other important landmark that this is the start of the superior vena cava. When we notice that it's this first rib and this the second rib, it's just in the first intercostal space, while the end of the superior vena cava, where it's well connected with the right atrium, here when we just move from the straight to this flaring, this considered flaring or just near the hilar point, this is the what we call cavo-arterial junction. And the preferred site for the CV line, whether from the right or from the right, to be here. Because actually study found if it's high in the superior vena cava, it may lead to increased risk of venous thrombus. And if it's just going down here more for on the right atrium, it's lead to arrhythmia. So also we have to ensure that it's properly positioning. So the optimum position for the CV line is at the cavo-arterial junction. And the common malpositioning, it could be, as we mentioned, in the right atrium, which will lead to maybe arrhythmia. Azygous vein, it may insert the azygous vein, or it may be in the vessel. It's not in the vein, it's maybe in the artery. So what we see here, this is the peripherally inserted. It's just below the clavicle. It's follow the direction of the vessel, going to the midline, and it's here. This is the flaring. We mentioned the end, the site where the end of the superior vena cava. Although it's a little bit going more down, but it's still considered as an acceptable location for an CV line positioning. And this also we can use CT. This is the left one also for assessment the proper positioning. This is the left internal jugular insertion. This exactly at the site of cavo-arterial junction. And also this is the right one. Let me follow this CV line. It starts internal jugular, descending down, but it's ended here. As we mentioned before, this is the first rib, this is the second rib. It's here in the first intercostal space, and this is just the beginning of the superior vena cava. We mentioned before that it leads to increased risk of venous thrombosis. So it's preferred to going more down, at least here, to ensure that it's in the cavo-arterial junction, not in the superior part of the superior vena cava. While here is in the contrary, it is the right one. It's okay, follow the direction of the vessel. It's descending, but look where it's go. It's go far beyond the cavo-arterial junction. It's in the right atrium and going more down. This also, as we mentioned, lead to increased risk of arrhythmia. And we had to mention that it's had to be a little bit adjusted the position of this CV line. Here, the patient have two CV lines. For example, this is the left one. Okay, it's right direction, it's going to the left, but it's ended here. As we mentioned before, it's higher location. But let me move the C to the right one. It's fellow first here, but it's just above the clavicle. There's a suspicion there's a malpositioning. And also when we notice that it's going down to the left, it's not going down here, it's just toward the left, it's highly suspicious that it's in the arterial subclavian artery, not subclavian vein, and that's what shows really in the artery, subclavian artery, and that's very important to assess. And here's the same. It's also start in the midline, there is no problem. But when we notice that it's not the usual site that we use, it's a little bit more lateral. And also that because it's arterial insertion, it's not a venous insertion. Here the CV9 just coiled and peripherally located, sorry, it's peripheral line, and it's coiled and peripherally located. It's neither reach the superior vena cava or the vessel. It's malpositioning CV9. And when we follow here, it started to go into the left, but it's just going upward. It's not going downward. This is because it's just entered the right brachiocephalic and going up. It's not descend to the superior vena cava. That's regarding the CV line. And lastly, we just have a brief slide about the biliary stent because we face it a lot. The important first that it's the proximal tip can be either in the common bile duct or in the hepatic duct. But the most important thing that it had to pass the obstruction. What the benefits of the biliary stent if it's just beyond the obstruction? It will not lead to any proper drainage. And the distal tip need to be terminated in the first or second part of the duodenum, just beyond the ampulla of water. We don't want it to be more than this because may lead to perforation or irritation. So this we see in the practice where actually the patient have an stent. Actually, the stent going to the third and fourth part of the duodenum, and we consider this stent as there's a slippage of this stent. And that's regarding the most important line in that we want to discuss. If anyone have any question?
شكرا جزيلا.